Hele goede avond allemaal en welkom op dit avondseminarie. Omwille van het feit dat we drie internationale gasten hebben, waarvan 2 Engelstalig, stel ik voor dat we onmiddellijk overgaan in het Engels. A very good evening to all of you and welcome to this webinar on the use of mortality data and the link with other patient outcomes. And it's a privilege for us at the Leuven Institute for Healthcare Policy to organize this webinar. It's a collaboration with the federal government patient safety group and our university. And for this evening, we have 3 international speakers for you, 2 from the US and 1 from the Netherlands. The different presentations will be in English, and after each presentation, we will have time for some questions. At the end of the overall seminar, we have some time left to have overall questions, and the 3 presenters will be able to stay with us for the whole seminar. So it's a privilege to introduce to you the first speaker of this evening from the United States. Sébastien Haneuse is a PhD in biostatistics affiliated to Harvard Chan School of Public Health in Boston, and he's also fellow of the American Statistical Association. Sébastien will give us an overview of his view on the hospital profiling based on readmission and mortality for high mortality conditions. Sébastien, you can take the floor and take over the presentation. It's a privilege for us to have you with us this evening. The floor is yours. You're still on mute, Sébastien.
All right, is that better now? Great. All right, well, thank you very much to everybody that's involved in inviting me. I've been speaking specifically to Astrid, but I'm sure that there's an army of folks involved, and I really appreciate the opportunity to be here and to talk a little bit about my research. As with most of my research, it's joint with a number of folks around the Harvard system, but in particular, Deb Schrag, who is health services researcher oncologist, used to be at the Dana-Farber Cancer Research Center and is now at Memorial Sloan Kettering. And this research arose from initial conversations with Deb. Curious, I don't know how narrow it is relative to the scope of the types of things that folks are interested in the audience, but I hope you find it interesting. The context is, initially at least, is thinking about hospital profiling based on readmission. Certainly in the US, even though it's not without controversy, hospital readmission is a key quality metric, for better or worse. There's sort of 2 key programs that are run by the federal government, the Hospital Inpatient Quality Improvement Program and the Hospital Readmissions Reduction Program. And both of them essentially institute financial incentives for hospitals to both report and reduce excess readmissions. And there's a big debate around what we mean by excess, and there's different philosophical perspectives. But the long story short is this is the current state of affairs as to how hospitals, at least in part, are reimbursed. The conditions that are currently covered by these programs include sort of acute myocardial infarction, heart failure, pneumonia, and 4 others. What's common to each of those conditions that are currently being considered is that generally prognosis is pretty good. You know, of course, it's not universally good for everybody, but it's generally pretty good, and mortality is generally pretty low. So when you're considering the totality of hospitals and you're looking at variation in these quality metrics that are constructed around readmission, if we don't really have to worry too much about whether there is variation in mortality across those hospitals, because the mortality is generally very low. And so when overall it's very low, whether there's any variability probably isn't going to have a huge impact on the performance metrics as they pertain specifically to readmission. So that's not necessarily going to be the case, though, for other conditions where prognosis is poor, mortality is high, and at that point, clinical management of patients typically focuses on end-of-life palliative care. And this is where some of my initial conversations with Deb Schrag came into being, where, you know, a few years ago, I didn't know anything about pancreatic cancer. There may be folks in the room who know a lot more about it than I do. The pancreas is a gland organ in the digestive system. sort of sits between, sort of right in the middle, sort of between your stomach and your spine. And so it's kind of really tucked away in there. And I always think about that through the lens of screening for pancreatic cancer. In a different life, I was involved in a big study of mammography, screening for breast cancer. And there, you know, mammography is a modality that is relatively easily accessible for folks. But basically, the long story short is there's no screening for pancreatic cancer because of where it lives inside your body. And so what that means is that most of the time, by the time the pancreatic cancer has been detected, it's actually a little too late. And it's usually diagnosed at an advanced stage. And at that point, prognosis is poor. To sort of make that a little bit concrete, in 2019 in the US at least, there were an estimated little less than 57,000 new cases. And the 5-year survival rate is only a little over 9%. So you get diagnosed with pancreatic cancer and 90% of new diagnoses only make it, pass away at some point within the next 5 years. Drilling down, being a little bit more concrete, I'm going to present some data, some illustrative data for the techniques that I'm trying to develop here. There are a little less than 17,000 patients from the Centers for Medicaid and Medicare Services. It's essentially a nationalized healthcare system for 65 years and older, you know, essentially. So these are folks who are diagnosed with, hospitalized with the diagnosis of pancreatic cancer sometime between 2000 and 2012. And for simplicity, we're just focusing on 264 hospitals in California. And I'm primarily interested in, you know, when we think about readmission as a quality metric, it's, of course, you have to be discharged to be readmitted. So we're focusing on folks who are discharged successfully alive. Folks, of course, can pass away during that initial index hospitalization. But again, because our interest is primarily in readmission, we're focusing on those who are discharged. So this is looking at 90 days. So 90 days following discharge, a little over a third of patients are readmitted into the emergency room. And why that's an important metric in the US, at least intuitively, is this idea that if you are discharged alive and that your whatever process is involved in your care following discharge, if things are going well, then you shouldn't be readmitted back into the emergency room. In the US, at least, admission to the emergency room is an incredibly expensive event. And so there's interest in mitigating those readmissions. So I said, you know, about a third of folks are readmitted, which overall is a lot of folks get readmitted back into the hospital. And I don't know exactly the details, but my understanding is it's often an issue with pain medications, that they're just not being managed properly, and then something's going wrong, and then suddenly they have to come back to the emergency room. But at the same time, in these data, you know, 50% of people don't make it to the 90-day mark. So you are admitted, you get a diagnosis of pancreatic cancer, 50% of people don't make it past 3 months. And so when we're interested in thinking about readmission rates and how do they vary across hospitals, and as some hospitals that have high readmission rates and others have low readmission rates, you can't ignore mortality. 90-day mortality here is 50%. And it's important to think about these 35% of individuals who died without readmission within that first 90-day window. So you've got this 90-day window that we're interested in, and I can talk a little bit about why we have that 90 days, but we've got that 90-day window. And we're looking at readmission over the entirety of that window, and then somebody dies within, let's say, 7 days. And they subsequently don't really have an opportunity to readmit, of course, because death is a competing risk in that instance. So if we're interested in readmission, and readmission exists as a quality metric, and we want to apply it to these situations where we've got a strong force of mortality, what do we make of these individuals who die before they have a full opportunity to be readmitted? Here's some sort of raw hospital-specific 90-day readmission and mortality rates. And it seems intuitive that they wouldn't be independent of each other. I don't know. Like if the premise is that we're trying to get at quality, for better or worse, and performance, seems intuitive that they would be related. But what we see from this figure, and there's no adjustments, I'm not pretending to think that this is sort of the be all and end all, this is not the final story, but what we see from this is seemingly a negative correlation if you sort of squint and look, maybe tilt your head a little bit. So it's suggesting that patients hospitals with high readmission rates tend to have low mortality rates. Intuitively, it sort of makes sense. Like if you're at a hospital where lots and lots of people are dying off within 90 days, they're actually not getting a complete opportunity to readmit. And so therefore, but if you just focused on readmission by itself, you'd think to yourself, oh, look, this hospital is doing great over here. It's got a readmission rate of less than 20%, but then its mortality rate is up close to the 80s. So of course, this is all unadjusted, and we need to sort of acknowledge and then account for differences in patient case mix. So some hospitals treat sicker patients than others. And just the general demographics, of course, vary across patients. So we need an infrastructure. If we're going to sort of try to do profiling, performance evaluations, we need an infrastructure within which we can account for the fact that patients, not all hospitals are the same in terms of the types of patients that they see. So what is the existing framing for the analysis of readmission? So I'll caveat this slide and a couple of others floating around. There's going to be a little bit of notation, but I'm hoping that it's not going to be too onerous, and I'm happy to answer questions. I'm happy to point you to a paper. I'm going to try to focus on the big picture points. But the long story short is, when you just think about readmission by itself, it's yes, no, you were admitted or not. And I'm hoping that most folks are okay with logistic regression. Just a logistic regression for a binary outcome. It's a hierarchical mixed effects logistic regression where this piece of it is acknowledging case mix differences. It's like some hospitals treat sicker patients than others. And then this over here is what we might refer to as a random effect. And that's really the hospital specific effect that ends up being the thing that distinguishes hospitals in terms of their variability of care. And then we can fit this model. Of course, these types of models have been around for decades, and we can fit it. And then we can use the output from that model to construct a quality metric. And ultimately, the metric that is used, at least in this specific context, is a ratio. And in the numerator, you got something that looks pretty complicated, but you can just think of it as the observed rate. It's like, and then in the denominator, you've got an expected rate. And it's like here, this is the observed rate for hospital J, adjusting for case mix in a particular way. And then here, this is the expected or standardized or averaged rate, where we're just doing some integration here for folks who like calculus. But nevertheless, it's an observed over expected, and hopefully that's intuitive. And then if you take the ratio of observed and expected, and you're like, and you see, oh, look, the observed over the expected is greater than 1. So what we observe is in some sense higher than what we expected. So this hospital's readmission rate is, in a sense, too high relative to what we would expect for their patients. It seems like a bad thing. Similarly, if the ratio is less than 1, then their observed rate is lower than what we would expect given their case mix. And so that's a good thing. And so this excess rate ratio, it has a number of other names, but this is a measure that then ultimately feeds into a somewhat more complicated formula that CMS uses to reimburse hospitals. And it's like, oh, if your readmission rate is lower than expected, that's good. And if it's not, it's not good. But this framing is just a binary framing. Were you readmitted or not? It doesn't actually acknowledge the mortality piece of it. In fact, what it would do is it would take somebody who died and just put them into this bucket because they didn't readmit. So you're mixing folks who died with who possibly are unhealthy, the least healthy individuals, with folks who made it without readmitting or dying. So you're mixing sort of two very strange groups of individuals. Nevertheless, we could just forge ahead and just do it. And we can actually apply that logic, that analysis, to readmission and to mortality separately. And that's what's going on here. So this is what you would do if you were using existing methods. You might get a figure like this. And again, bigger than 1 is bad and less than 1 is good. So we've got readmission here. We've got mortality on the y-axis. All of these hospitals are good hospitals in the sense that they have like lower than expected readmission and lower than expected mortality, while all of these red hospitals are hospitals that are poor performers on the two metrics. And then the hospitals on the off diagonals are poor performance on one, good performance on the other, at least. But the underpinning analysis here is it's sort of two completely separate analyses that doesn't acknowledge the sort of the interplay within individuals between readmission and mortality. And in particular, the readmission analysis, there's an argument to be made that if you're completely ignoring mortality, then there's the potential for bias there. And not just that, but you're in this situation where I would argue inappropriate handling of death. Just, folks may be familiar with competing risks analysis and survival analysis. It's a similar phenomena that's going on here. You could end up with a hospital that has a low readmission rate, which looks good, possibly because they're doing a poor job of keeping patients alive. And similarly, a hospital may be doing a good job of keeping patients alive, and that may be the reason why they have a high readmission rates, because they're dealing with difficult patients who have difficult clinical situations, and then they're really doing a good job of keeping them alive, for better or worse, and then they have a high readmission rate. So the entire premise of all of this is how do we learn about variation in readmission rates while kind of quote unquote accounting for death? So long story short, is we developed a framework that's embedded within this semi-computing risks framework. Folks may be familiar with computing risks. Usually computing risks is you die from one cause or you die from another. You die from cardiovascular disease or you die from cancer. And usually you don't get to die from one and then subsequently from the other. It's an either or event. In the semi-computing risk setup, the idea is that one event is competing for the other, but not vice versa. So in the readmissions context, if you have you are discharged post-diagnosis, you can readmit and then die. But of course, if you die, you cannot subsequently readmit. So here we got this, it's sometimes referred to as an illness death model or a multi-state model more generally. And there are these transitions that occur between these states. And we model these transitions with essentially a Cox model. So for folks who have been familiar with the Cox model, it's everywhere in clinical research. This is really not that different. You just got a couple of extra ingredients and then a lot of technical detail that I'm not going to go through. And the ingredients really are just these frailties here that acknowledge we're observing two things on the same individual. So we want to connect. We want to acknowledge that your outcomes are correlated or dependent in some way. And now instead of having one hospital-specific effect, you've actually got three hospital-specific effects. Right? Because there's quality that's associated with a hospital's readmission rate, there's quality with a hospital's mortality rate prior to readmission, and then a quality metric with post. There's a lot of detail, I'm not going to go through it, but we've got a framework, you can do an analysis, we fit the models, and from these models, of course, these are sort of Cox regression type things, so you get a hazard ratios instead of odds ratios, and we can look at this, and I'm happy to talk a little bit about it in detail. But ultimately, the premise is we wanted to look at hospital profiling. And I gave you that observed over expected metric. From the fit of this model up here, I can compute two new metrics that we've developed. I'm not putting any of the details here, but essentially you end up with a metric for readmission, and then you end up simultaneously with a metric for mortality. And because all of this is sort of within the survival analysis framework, it actually ends up being a function of time. I'm just going to show you what's happening at 90 days, but you could take the fit from the model and look at 30 days or 120 days, whatever you want to do. Both of these quantities are, again, observed over expected. But the fundamental difference from what I showed you before is that they come from the same modeling infrastructure that acknowledges that, we're talking about multiple observations on the same individual. And the key difference is, I haven't shown it to you, but the way in which we define this readmission metric is that it's conditional upon being alive. It doesn't really make sense to think about readmission among folks who have already died. So there's a very specific interpretation for folks who are familiar with computing risks analysis based upon a cumulative incidence function. We don't need to go into that. I'm happy to send the paper for folks who are interested in. Just a couple more slides. One is this comparison between looking at readmission ratios, so 90-day readmission, under the old analysis that ignores mortality versus the new analysis that does not. So if you take this hospital here, you're basically getting the same results. It's great. You take this hospital over here, this green hospital. Under the old analysis framework that ignored mortality, you get the impression that it's actually, a really bad hospital. They've got a very high excess readmission rate, like, close to 20% too high. But under the new framework that acknowledges in the background this hospital's mortality rate, it actually brings it down, and we find out actually that no, they're actually doing pretty well. When you explicitly acknowledge the mortality rate, you find out that this hospital is not doing that badly. Actually, it's actually doing okay. These red hospitals are over here where you think in the beginning, oh, this hospital is doing great. Like its excess readmission rate is actually the lowest. It's like close to 80%. But then when you acknowledge the mortality rate in that hospital, it turns out they're not doing that great. And so when you transition from the old analysis framework to the new analysis framework that we propose that it directly acknowledges mortality, you get different results. Here are the actual results when you look at them simultaneously. You've got readmission and mortality simultaneously from within the same framework. And we're still able to put hospitals into buckets. There's still 4 buckets. It's like, these are the good hospitals, you know, or at least the good performing hospitals. These are the poorly performing hospitals. And here, and what this suggests to me, at least, and I'm not a policymaker, so I don't, you know, it just seems intuitive that this would be the case, is that these hospitals here, like, there's not really much we need to do for them. All of the other hospitals are performing poorly in one way or another. But these hospitals are performing poorly in regard to readmission, and these hospitals are performing poorly in regards to mortality. It doesn't seem like we will want the same policies for both of those types of hospitals. We want to elevate them in terms of the things that they're doing poorly, but we don't want to change anything for the things that they're doing well. And so it strikes me that there's an opportunity for future policies to be tailored on the performance of the 2 metrics in tandem simultaneously. So I'll finish off with a few comments. The methods that are currently used for hospital profiling ignore death as a competing risk. And sometimes that's going to be fine. Sometimes I don't think it's going to make any difference whatsoever, including in all of the conditions that at least the Centers for Medicaid and Medicare Services are currently looking at. But it's likely, I think, to be unreasonable for pancreatic cancer and other terminal conditions, or maybe looking at heart failure in certain subpopulations for which risk of mortality is high. So we have this framework that's trying to think about how to resolve this, how to think about resolving death as a competing risk in this instance. In this instance, though, initially death was viewed, at least by me and my group, as a statistical nuisance. It's like, ugh, it's a pain. How do we get rid of this competing risk? In the end, though, I've actually completely changed my philosophy. I really think that the appropriate way to view this is sort of as an opportunity to sort of develop new policies that are tailored and specifically think about readmission and mortality separately. I think it's artificial to separate them in these particular contexts. And I actually think that it's not, you know, it's not just artificial conceptually, but it's just not how we think about it. When we go to the doctor, we don't think about one aspect of our care and then forget about that and then go over here and think about some other aspect of our care. We're thinking about these things simultaneously. And I think that there are opportunities to do that. We've got a paper that was recently accepted. I'm actually not quite sure what its publication status is. It's out there. I'm happy to send it for folks who are interested. And we've implemented all of these methods in R. Yeah, so happy to answer some specific questions and then, but also pass the baton on to the other speakers.
Thank you, Sébastien, for this interesting lecture and the presentation. And of course, both the indicates mortality and readmission are indicates that we're all looking at. We have time for some questions, and I know there are clinicians in the webinar, there are policymakers on the webinar, but there are also some statisticians in the webinar. So please feel free to unmute yourself and ask the question. Who will go first?
I've converted everybody.
Oh, Bianca.
Thank you, Sébastien. It was a very interesting presentation. I was wondering, did I see well in one of your first slides that you only consider persons discharged alive at the first? Okay.
Yeah, and I think that, well, the premise there is that, you know, mortality is not really, again, the framing is somebody is admitted to the hospital, they get a diagnosis of pancreatic cancer. Some of those individuals pass away during that hospitalization. for those individuals, they never become at risk for readmission. Like you have to be discharged in order to readmit. So if we're interested in readmission, I think I don't really see any other path forward except for to focus on folks who are discharged to life. It's not to say that in-hospital mortality is not important. It's very important, of course. But I think in the context of readmission, I think it makes sense to focus on people who are discharged to life.
Yeah, because we have also been doing a type of analysis where we look at mortality, readmissions, and length of stay, but then separately. And we were trying to cope with this problem by looking at readmissions only for the people, for the alive ones. Do you think that's still problematic?
No.
Because we don't have information on like 90-day mortality. We only have information on in-hospital mortality.
Oh, I see.
Yeah.
Yeah, that's tough. Yeah. Sorry, that's tough. I misunderstood that.
So we can't use your approach, I fear.
Well, yeah. I mean, I guess for here we link. There is a linkage with death records. I guess I don't know what the it's external death records that get linked to be able to identify whether and when folks pass away outside of the hospital. You definitely need that information to implement this.
Yeah. So I think our best option is just to focus on the alive discharges to calculate our readmission rates.
Well, no, because the problem is you don't know among those individuals. I mean, if you're looking at some window, I don't know if you're looking at a 30-day or a 90-day window. If you take the denominator of individuals who are alive when you're discharged, I think the argument that I'm putting forward is that you need to know in the numerator how many people to include. If you don't have any death information, you'd end up conflating people who do not readmit because they died early on with folks who do not readmit and they're still alive. Yeah.
Things to consider and to think about in the next.
I'm happy to have another conversation with you if you want it.
Yeah, thank you. Very interesting. Thank you.
Yeah, that would be great. Time for one other question. Is there another colleague? I don't see any other questions, so we will keep the others for the end of the presentation. And I suggest then, and the slides are already there, the slides of Larry Allen. Thank you, Larry, for your time and to be with us this evening. You're an associate head of cardiology and a medical director of advanced heart failure, affiliated to the School of Medicine of the University of Colorado. But I also saw on the internet that you were elected top doctor by your peers, so that they really trust you. So we also trust in you as a medical doctor, but also as a presenter. So it's a privilege for us to have you with us. Larry, you have the floor.
Great. Can you hear me?
We can hear you.
Wonderful. So Astrid asked me to talk about the merging of clinical and administrative databases. And I'm going to use the Get With the Guidelines registry or clinical database from the American Heart Association. This should be hopefully a nice complement to Sebastian's talk for a couple of reasons. One is he was using administrative data, and so we'll talk about some of the differences between that data and clinical registry data. The other is we're going to talk about heart failure rather than pancreatic cancer, but we will discuss both readmission and mortality. So we'll be kind of at least in the same realm, and how do you compare hospitals? And then lastly, Sebastian is a PhD statistician, and I'm largely a clinical heart failure doctor. So I certainly bring a much different perspective to the analytics here. So the American Heart Association is in the United States, a patient-centered not-for-profit. They take money from a variety of sources, including donations from patients and families. But they also run our CPR courses in our country. And one of the initiatives that they've done for about the last 20 years is the Get With the Guidelines program, which is a quality improvement program primarily focused at the hospital level, helping hospitals collect clinical data on stroke, heart failure, resuscitation from sudden cardiac death, atrial fibrillation, and coronary artery disease, collecting that clinical data and then adjusting it and benchmarking it and feeding it back to sites in terms of both their processes of care and their outcomes of care to try and improve the quality of care at hospitals related to cardiovascular disease. So there are, as I mentioned, there are 5 different registries, and this has even proliferated some beyond the hospital setting, but resuscitation was first in 2000, and then more registries have been added. The stroke registry is actually the largest, and it now has about half the hospitals in the United States that participate. Participation is voluntary. And heart failure has about 700 sites that are actively participating. And this has generated millions of hospitalization episodes with data entered into the Get With the Guidelines system. So here's the website for the Get With the Guidelines heart failure program. It talks about that this is an in-hospital program designed to promote consistent adherence to the latest scientific treatment guidelines. And again, performance feedback reporting for continuous quality improvement is the primary goal, but there are a number of secondary goals, including just characterizing what's happening at hospitals across the United States in terms of these key conditions. So this shows you what kind of data is collected by these various registries. In the middle column, you can see heart failure. So it collects patient medical history, including a number of demographics. It looks at the medications when the patient arrives at the hospital. It collects a variety of procedures that happen during the hospital stay, such as coronary revascularization, as well as defibrillator implantation. It looks at the medications that were given during the hospitalization, such as intravenous inotropic support. And then it has discharge medications, including dose and frequency for key medications that relate to the disease of interest. And it collects contraindications to that. And then it also looks at some of the other aspects of care, such as counseling and education, and whether the patient was referred for post-discharge care. This is a mock-up of the clinical detail that's collected by the online data retrieval system. And I think one of the key aspects to highlight here is the data that Sebastian is looking at. Administrative data may say that a patient has a history of hypertension. And sometimes it will collect a diagnosis in the administrative data of hypotension. But the clinical data from Get With the Guidelines collects what is the heart rate and what is the blood pressure when the patient first is admitted to the hospital. And that level of clinical data, in my mind, is really critical and quite different than administrative data. And that's also quite relevant to the management of a disease like heart failure, where the patient's heart rate and blood pressure are strongly predictive of their outcome, and also are important in determining whether patients are eligible for key therapies. Similar to that, lab data is collected. So in the administrative database, a hospitalization can have a diagnostic code for hyperkalemia applied, or a diagnosis for acute renal failure or chronic kidney disease. But the labs at admission are actually just collected here quantitatively, which again gives an incredibly higher level of data exactness, which again is important for prognosis, characterizing disease, characterizing the patient, and what they're eligible for. The other key aspect here is that the therapies at admission and discharge are collected, so you can see what people are actually doing in terms of their process of care. And I think one of the real important aspects is that if a patient should be getting a drug like an ACE inhibitor or a neprilysin inhibitor, then it either collects that they got the drug, what the drug was, what the dosage was, or if they didn't get it, not only was there a contraindication, but it requires which accepted contraindication was present. And if there wasn't an accepted one, then you can't say that the doctor felt that it wasn't appropriate. This is how the data flow works for Get With the Guidelines. The hospital decides to voluntarily participate in the program. They pay a nominal fee, like about $5,000 a year to participate. The expense to the hospital largely is driven by the cost of human resource. So having somebody go through the clinical records and then upload it into the system. There's been an effort to create automated upload from the electronic health records into the data system. But if you look at hospitals here in our country, about 70% of them either use Epic or Cerner, but there are a number of other hospitals that use different electronic health record systems. And even within an electronic health record like Epic, there's a lot of customization. And so automated upload of data has been very challenging. So once that data is uploaded into the IQVIA software, then it is delivered to the Duke Clinical Research Institute, which actually cleans the data and then coordinates analysis. And then there is a de-identified data set that's created called the Precision Medicine Platform, which allows for additional analyses separate from the benchmarking and feedback. So Get With the Guideline data characteristics. The advantages are clearly that there's detailed clinical data and collection of processes of care. But the huge disadvantage is that once the patient leaves the hospital, there's no further data capture. So if a patient dies in hospital, you can collect in-hospital events like death. But if you want to look at 30-day or 1-year mortality, there's no real way to do that from the Get With the Guidelines clinical registry on its own. So this is where merging to the Medicare administrative database can be helpful. So here in the United States, we're a federation of states. We're less centralized than European governments. But for Americans over age 65 for the last 50 years, health insurance is provided centrally by the federal government. And additionally, there are some people on disability and all patients who are on dialysis who qualify for Medicare health insurance. This covers 18% of the US population, which is a problem if you want to look at certain diseases of younger people. But in the United States, 80% of people with heart failure are actually over 65. And so the vast majority of patients actually have their heart failure care paid for by Medicare. Medicare has different structures to it. The majority of people are in traditional fee-for-service Medicare that has different parts. Part A looks at inpatient hospital facility fees, as well as nursing facilities, hospice care, and some home health services. Part B looks at physician services, both inpatient and outpatient, as well as outpatient facility fees. And then many patients now have a Part D plan that they have to opt in for and pay a nominal fee to get, and that covers prescription drugs. So it is possible to also look at what drugs patients are getting, both inpatient and outpatient. Many of these programs are being converted to a bundled Medicare Advantage plan, which is able to collect what's done under that bundle. And then data collection is anything that hospitals or physicians or ambulatory facilities bill for, including hospitalization events. But Medicare is also very in tune to when patients die, and so they collect that data quite accurately. So the key then is to say, well, you've got a good high quality registry like the Get With the Guidelines registry, and then you want to merge that with Medicare data. And so Leslie Curtis at Duke University in the United States, as well as Brad Hamill and some others, have done a lot of merging of Medicare data to clinical registries. And there's a couple of papers here I put down that talk about how they've done this over the years. But basically you clean your registry data in certain ways, you clean your Medicare data in certain ways, and then you try and link them by hospital identifiers. And you can do this by admission and discharge dates, as well as some demographics like patient date of birth and sex. And then you end up creating matching sets and throw out certain patients where you're not sure if you have a good match. But this generally leads to very good matching and combination of the data that then gives you the strengths of both. So Get With the Guidelines now has resulted in over 600 publications. And a lot of these publications actually are enabled by the combination of the Get With the Guidelines data with Medicare. So I'll finish in the last third of the talk talking about using Get With the Guidelines and Medicare merge data to better understand hospitalized heart failure and the effect of policy changes on this. So heart failure is the leading condition associated with readmissions and admissions in Medicare. We have about 1 million hospitalizations in the United States for heart failure every year, and 20% of those patients are readmitted in 30 days. Relevant to the last talk, about 9 to 10% of people die in that period as well. And the mean cost of a hospitalization in US dollars is about $14,000. The total cost for readmissions ends up being in the billions of dollars for Medicare. So health policies that have over the last kind of decade led to attention on heart failure care and heart failure readmissions and mortality were initially in 2009, the required public reporting of 30-day outcomes by hospitals according to their Medicare patients. This then led to the hospital readmissions reduction program that Sebastian mentioned, which actually has penalties to hospitals for higher than expected 30-day readmission rates for heart failure, as well as pneumonia and heart attack. And then in 2014, the value-based purchasing program went into effect that Sebastian also mentioned. So this is what Care Compare looks like. This is the public reporting system for Medicare. So if you go on to the Medicare website, you type in Care Compare, you can actually click on the hospitals and you can get a whole bunch of ratings about how hospitals are doing. These are, I just pulled these today for our hospital, the University of Colorado Hospital. And it says that our death rate for heart failure patients among Medicare was 8.3%, which is better than the national average of 11.2% at 30 days. And our rate of readmission is, for our Medicare patients over 65 is about 20.6%, which is slightly below the national average of 22%. So this is from Kaiser, where they look at the Medicare penalties related to this. So about half the hospitals in the United States had a reduction in their Medicare payments, anywhere from 0 to 3%, but usually this was about 1% of total payments. Since about 30% of payments to hospitals are Medicare payments, 1% of that is 0.3% of total payments, which for a hospital system is not trivial. So if you look at this program, the public reporting went into place in 2009. Then there was an implementation phase with rollout of the hospital readmissions reduction program in October of 2012. And you can see in the blue line that the targeted conditions of heart failure, pneumonia, and myocardial infarction actually started dropping during the implementation phase and then have been relatively stable since rollout, or at least in the first few years. And non-targeted conditions, so something like gastrointestinal bleeding, also had a little bit of reduction, but not as much. So the CMS incentives for readmission prevention are much bigger than the hospital performance mortality rates. So if you look at the penalty that hospitals get, there's a potential 3% penalty looking at the hospital readmission reduction program or readmission rates. Whereas if you look at their mortality rates, it's really 2.2% of their total payments. So there's been a real emphasis on readmissions and not so much on the mortality rates. And there's been concern that this has caused perverse incentives or unintended consequences. So this is administrative Medicare data from Sebastian's colleague, Sharon Lise Normand, as well as others, showing that the institution of the HRRP around heart failure readmissions showed a pretty significant decline in readmission rates over time, with no real change in 30-day risk-adjusted mortality. However, there's a lot of concern among people that these administrative data don't really adequately adjust for all the differences between patient characteristics, both in terms of patient medical characteristics, as well as some of the social characteristics that could influence outcomes. So we use the Get With The Guidelines data merged with Medicare to look at the association of the hospital readmissions reduction program implementation with readmission and mortality outcomes in heart failure, and to compare this to the data that was being generated out of the Medicare admissions data alone. So we started with Get With The Guidelines data with about 500,000 patients. Most of the exclusions were because patients were either younger than 65 or they didn't have an adequate linkage to Medicare. And then we ended up with about 115,000 patients and looked at those patients across time. And you can see that there's a slight reduction starting in 2012 when the HRRP went into place, but this reduction was less than was seen in the Medicare alone data. And then what's a little concerning is that there was a slight increase after the HRRP went into place in terms of mortality rates among hospitals. And so it was hypothesized that what would happen is that hospital leaders would increasingly avoid readmitting high-risk patients who needed readmission to stabilize them, to try and keep them out of the hospital or to discharge them from emergency departments, and that this might lead to a higher mortality rate. The other is that there was some thought that people would try and delay the admissions past the 30-day window. And if you look at readmissions at 30 days and you look at the reduction in readmissions at 1 year, there's some evidence that that may be happening as well, because the reductions were bigger in the short-term phase. And then observation status, or patients who only stay in the hospital 1 day, do not count towards these metrics. They're not considered an admission. And there was some concern that people would push for very short stays under observation status, which may not be appropriate for 6 patients. And you can see that the use of observation stays did increase a little bit more for the blue targeted conditions. And then finally, some of these numbers in administrative coding can be gamed by administrative upcoding. Whereas if you're using a clinical database that just has, absolute values of creatinine and blood pressure, that you'll end up with more accurate data. And there's an estimate that 2/3 of the reduction that we're seeing in heart failure readmissions is actually related to administrative upcoding and not real changes in the actual readmission rates. And then finally, here's a comparison of some of the clinical risk adjustment with administrative, just Medicare risk adjustment. And you can see at 30 days, if you compare the purple clinical data to the blue administrative data, that the increase in mortality rate is more. At a year, this is exacerbated even more for the clinical data. And then if you look at the reductions in readmission, you can again see that it seems to be overestimated in the blue administrative data only compared to the clinical data. So I'll leave you with that as a comparison between clinical data merged with administrative data versus administrative data alone. Thank you.
Thank you, Larry, for the presentation and to focus also on the difference between these administrative data and clinical data. There is time for 1 or 2 questions.
Thank you so much, Larry. I might have a quick question. Having seen both your presentations now, would you think that maybe Sebastian's solution by combining the two metrics together could perhaps solve a few of the problems that you've seen in the paper that you've described, these perverse relations that are now existing?
Yeah, I mean, I think that that this issue of competing mortality in terms of how you adjust or think about patients at risk for the event of readmission is a little different than not capturing detailed clinical data that then goes into the adjustment process. So he's really looking at who's at risk. And what I think I'm trying to focus on is what's the data to compare patient differences or both over time as well as between hospitals. And I think both are important if you're trying to, grade hospitals on their performance. So I think that the two talks are actually quite complementary. And I think you could say, well, we would like to have really high quality data, clinical data merged into the administrative data so that the adjustment process is optimal. And then ideally, we wouldn't just report clinically adjusted readmission data alone, we would report that adjusted for time at risk related to mortality. So to me, they're very complementary approaches.
Yeah. And we will have to be careful also with the clinical databases, I think, with the level of detail, because when you gave the overview on the cardiology, there were a lot of clinical details, which is, of course, very interesting from a clinical point of view and a research point of view. The question, of course, is what is the level we need for policy making and to combine these indicators. So it will be, I think, the balance between the administrative data, not enough, and with the clinical data, maybe too much detail. So what is your view on that for the future of the clinical databases? Less data or even more details?
Well, I agree with you. I mean, I think more is not always better, and over complexity is not helpful. So, sometimes like the word simplexity, right? Let's make it as simple as possible, but include all of what we need. I think one of the ways forward here, though, is that with the increasing technology in terms of electronic health records, with standardization, ideally what happens is that our administrative databases increasingly have automated upload of key variables like creatinine or blood pressure that then feed into the administrative database. So when we start talking about administrative databases, these administrative databases are actually increasingly accurate and increasingly clinical without requiring these separate parallel clinical resources. So to me, that's the way forward. And the prior merging of clinical databases helps us understand what variables do the administrative databases really need to make sure that they upload, and what needs to be standardized at the EHR level so that we don't miss it.
Yeah, that will also be one of the challenges for our country to make these choices, and also the link with the electronic patient records will be important. Although you also say that even with Cerner and Epic, the big two in the US, that there are still a lot of consultancy work that is necessary before you can integrate these data.
Yes, I mean, some of the problems is it's great to have this freedom for EHRs to be able to innovate and create their products. But the problem is the business plan is that Epic is happy to come to your hospital and give you as much specialization as you want. So you're paying consulting fees to get exactly what you want. And what you end up having is a lot of specialization, lack of standardization. And so it really harms the ability for us to do what we want to do, which is kind of compare hospitals and create, policy based on performance.
Yeah, thank you, Larry. And I also take with me the topic that you were saying, be careful with the link, but also with the gaming, the upcoding, all these problems, we have to take them into account. So thank you, Larry, for your presentation. And looking at the time, I would like to introduce you to Jacob Tamsma, Medical Director of the TechMed Center at the University of Twente and the Medical Director of our colleagues at Leiden University. Jacob, privileged to have you. Van harte welkom vanavond. The floor is yours. You're still on mute, Jacob.
I will try to share my screen. Do you see my screen now?
We can see your screen. You can put it on presentation mode.
Yes.
Yeah.
Okay. Now I only have one problem. I don't see you, but I will start talking anyway.
We can see your slides, but they are not on presenter mode.
Let's give it another try. And
Yep, now they are.
okay.
Thank you, Jacob.
Well, thank you, Chris, for your nice introduction. And I think we shift gears a little bit now to the practice of a medical director. My own background is in internal medicine and vascular diseases. And I became medical director at Leiden University Medical Center in 2010. And before I start on sharing with you a little bit about what I learned during the last couple of 10 years regarding the ASMR and the SMR and how to use it, it's perhaps good to have a little bit of context in 2010 about the Dutch health system. In 2010, we had just gone through a change in the system in that our government wanted to have more what we call in Dutch marktwerking in our system, which in fact was the result of thinking that you should design healthcare as a market economy system, which resulted in quite a lot of competition between hospitals and care providers on the one hand side. And on the other hand side, there was a wish of the patients and the clients, as they were called in that system, and also by the insurance companies to know what they were buying. So in that period, from the system change, there was a call for transparency. And in addition to that, we were in the situation that you may recall that there was an increasing awareness of quality issues, not in the least part due to scandals in healthcare. And journalists in the Netherlands were asking if this can happen in England or other parts in the world. How about the Netherlands? And this is a slide from our colleague, Professor Job Kiewiet, a slide from, I think, 2010 or 2009, in which he collected some of the articles back then. For instance, this one in the middle is an article in 2008. And all these articles in that time period had questions like mortality rates, yes or no, the public should know, why don't we share this kind of information, etc., etc. And although things went quite slowly, it step by step changed a bit. And for instance, in 2013, there was this article in a Dutch newspaper that told their readers that 65 hospitals had released their ASMR in 2013, and 6 hospitals had also given their SMRs. On the other hand, it's very small, so perhaps you can't see it, but there are about 100 hospitals in the Netherlands. So 26 of them were in 2013 not willing to share or able to share those data with the public. And this was a bit of the background in the Netherlands in 2000, well, let's say 10, to 14. For me, my personal approach in that period was that I was quite skeptical about it. I was not convinced that ASMR or SMRs could help us in improving our care. And I was a little bit on the side of those who said, this is a lot of journalism and what's in it for us as a hospital? Is it really working? I doubt it. That was my state of mind in that time period. And then the ASMR of LUMC came back from the data centers, and it was shown that our ASMR was 123. And if I recall it correctly, this for me was really a moment of activation in this field. And the first things that came into mind was, what should we do? Should we become defensive because the public opinion can be against us? It may harm our image to the public. How about the journalists? Will they come to us? There was quite some attention at that time period in the Netherlands for this kind of data. So that were all kinds of defensive thoughts that came into mind. And on the other hand, we had this feeling, well, perhaps it is also a possibility. Could it be that we could use it to improve outcomes? And then, of course, the second thought was, what does it mean anyway? And in that regard, we already have learned this evening quite some insight in what it does mean. And in fact, this is very simple, just from a physician. What it means is that it tells you something about observed mortality in relation to expected mortality. And this equation has quite some factors that will influence it, especially the expected mortality. For instance, the diseases which are included, an index of comorbidity, urgency of your admission, social economic status, age, and a few other factors that will be of influence on what you can expect. And going back to the 123, the question for us was, okay, is it the observed mortality too high, or is the expected mortality too low? And what kind of differential diagnosis in doctor's terms could you make for each of these approaches? So we considered this kind of things, and on the other hand, we thought, well, we can just regard it as a signal, and how can we further address the signal? Could it be a signal of damage that could be prevented, avoidable damage in our patients? And what can we do? What was really very nice was that in LUMC we have Job and also Perla Marang, one of my colleagues, who in my opinion is really a magician or a kind of wizard in this kind of data approaches and data analysis. And I asked Perla what could be a logical approach to do in this situation. And Perla analyzed the data, and she said, well, one of the things we can do is that we look further into 3 of the diagnosed groups that really gave a signal that there could be something happening there, could be something of interest. And Perla did some further analysis. We were in those days also collaborating internationally, so we had quite some tools. And then the next step was that we invited colleagues from the departments, from the 3 departments that were involved in the patients with those particular diagnoses. And we invited them and we explained them what was at stake and what we had seen in the data. And Perla also was able to have some hypotheses on what based on the differential diagnosis, as I just mentioned, what could be happening. And they were really intrigued by these insights. And so what we then asked them, and sometimes we even we didn't have to ask them, they came up with it themselves. They said, okay, we will get back to the charge of the patients and review them, and we will look what we can find, and we will have a look whether or not there could be avoidable damage, and how we can interpret these data. And then 2 weeks later, we met again, and we found out that the hypotheses formulated by Perla were correct. And for instance, one of the things that I found very intriguing was that our Department of Transplantation had changed their admission criteria for high-risk patients, thereby changing the case mix without, of course, changing the model, with an increase of the SMR. And the results were such that they already had some hesitation whether or not they should include these patients in the program. But this kind of new insights really fueled the conversation of their approach, and in the end they changed it. So for me, this experience of these 3 groups, which all had same experiences, really changed my view on the potential of administrative data as a signal for quality improvement. And perhaps when I think of it now, we also had some favorable conditions. And those conditions were that there was quite some trust and respect between the doctors at the LUMC and Perla and myself. And our mindset was to investigate and to try to improve, and especially not to judge. So the first lesson for me was that this kind of administrative data really are a useful tool or a useful signal to learn about where to look for potential quality issues in our hospital. Then, in the meantime, there were also some international collaborations in which we entered. And for instance, the Dr. Vostok Global Comparators was very active in those days. Later, Global Health Data at Work, in which Leuven was a very strong proponent and one of the leading hospitals. And what was really interesting in this international efforts was that it was not only international benchmarking, but it was also a community of very quite different groups from your system that were entering in the system. So we had board members, we had quality officers, we had physicians, researchers, and all had their own perspective on benchmarking and quality improvement. So I really have good memories to those days. And how did it further evolve in the Netherlands? Well, in the Netherlands, the health inspection authorities now use this kind of information in their yearly review of Dutch hospitals. And here you see one example that we provided for them in 2015. So a few years later than I initially showed you. And at this moment, this kind of reports are yearly presented to us. And this year we have a special insights in the Netherlands in, for instance, how we performed in relation to COVID. And this is the standard report we've gotten this year from the DHD and CBS. CBS is the Dutch Central Bureau of Statistics. Okay, so then you think, well, everything is okay at the LUMC. Well, there is another lesson, I think, to be learned. And that is that last year, we unexpectedly, despite all the efforts we took into, unexpectedly had an increase of our ASMR again. So we analyzed it, we checked the files, and luckily we did not find avoidable damage, but the signal it gave us was that we had to resign our process, and that we have to create a process that is really embedded in our quality system, and that's what we're currently doing. And in addition, we don't like the situation in that we have a yearly report and then steer on it a year later. So we now have another tool in which we can have a shorter feedback loop. So this, for instance, the picture you see here on the lower half of the slide, you see the results of this year from the first month. We still have a lag because this is the last report we had, and well, the letters are too small for you to see, but this is July, so we are still lacking a few months here. But we have some insight in how we are doing, and now we have the possibility to check on the registration. You should know that in the Netherlands, our codeurs, we call them, have a way of working, and we can give them feedback on that. And on the other hand, we have now a few dedicated doctors in the hospital that we use to have a look on patient cases that come out of the tool to have a check whether or not there are quality issues. So to summarize it a bit, after I'm not so a quick learner, I think, because it took me 10 years, but my lessons are that ASMR and SMRs are a very useful tool and signal to learn about quality. If you want to use it, be aware of the conditions you create of trust and respect and mindset. What I also have that, and I'm lucky to have it, to have dedicated colleagues like Perla, who are really have the how-tos in their toolboxes, and then I would advise everybody to create a process to embed it in your quality system. So, Chris, I think for now this would be a first introduction in how we handled it in Leiden.
Thank you, Jacob, for the overview of how you worked with it at Leiden University. And I think we recognize a lot of the work that you have been doing, and that it takes time. And maybe you think that 10 years is slowly, but we see that all major improvements take time also to learn from the data. So thank you for sharing your expertise and your experience with the HSMR. We have time for one or two additional questions. Who has got a question for Jouke?
I have a question. Hallo Jouke. We
Hello,
zien
good
elkaar
evening.
terug. Goed je te zien. I will speak in English, but I know Jouke from a long time ago, so it was happy to meet here. Jouke, you tell us you have codeurs, so people who register the data, the data in the EMR. You come to an HSMR through these data, and then you need a doctor for interpretation of the data. So what you're telling us is ASMR as such is not. I don't do anything with it unless I have a doctor to analyze on the EMR to see if I can improve the quality. Is that what you're telling us?
Well, I think that's a part of the story. Very nice to see you again. Although it's very strange to use the screen for it, but good to see you again. Well, the first thing is that you need a process to enter the administrative data and to add them into the Dutch system, and that's done by the codeurs. For instance, they have in the Netherlands a rule that they use the letters of the doctor when the patients leaves the hospital, and they use only that letter for their registration. So that, for instance, is one thing that that doesn't always give the best results because you are dependent on the letter of the doctor. But anyway, comorbidities are added, etc., if they are available, and then you get the signal back from the DHD, which is the ASMR. And then what my advice would be is that you think of a process, how you will use that information. And I take that information very seriously now, and there are several approaches you can do. And one of the approaches that we are currently working on is to ask Perla, where do we have to look? And then those patient records will be reviewed by the medical specialists.
So it's a collaboration between the statisticians and the clinicians.
Yes.
And I think that is also one of your main takeaway messages on HSMR.
Yes.
Okay, thank you. Time for maybe one other question or some comments from Larry or Sébastien. A question from Aaron. You can take.
Yep. Just start the video. Thank you very much for all the nice presentations this evening. I had one question for Jouke. In which way do you think that you're doing a sort of quality improvements rather than a coding improvements?
Yes, that's a very good question. And actually what we are trying to do now is both. So we want to step by step improve the registration and the coding, hopefully also reducing noise by it. And then what is the next step is that if you get the signal back, you can rethink what you're going to do with it. And for instance, the approach of Sebastian is very interesting also, because you can combine signals with each other, because everybody here in the audience will recognize that you've got a lot of signals in your hospital, and these are just one portion of it. So by looking at in several directions, you can get a good feeling where to go for improvement.
Okay, and so just one additional question. And do you use it in an individual feedback towards your doctors, or are you doing this on a departmental level or general hospital level?
Yes, or a subgroup of specialists. So far in our hospital, we never use it for a direct feedback to one particular doctor. I think a safe environment and trust and respect, and to be very careful about judging and blaming, etc., is very important in this. If you really want to improve, people have to dare to speak up and have the good incentives. The incentives, as Larry showed, can be very important in this field. So trust and respect and a safe background is, I think, very important.
Okay. Thank you, Aaron, for the questions. I look at the time, and although this was not prepared, could I just ask to Sébastien, to Larry, and to Jacob if they have some one take-home message for our people who were on the webinar? Is there one take-home message that you want to additionally provide? Maybe Sébastien, you first.
Sure. You know, I mean, I was just fascinated by both talks. You know, I think that it just sort of strikes me, you've got three very complementary talks talking about essentially the same broad overarching phenomena from the perspective of three different people who are kind of working in the trenches with it all. It was just very well structured and very interesting set of talks that you guys put together. Thank you. Yeah.
Okay. Do you agree that it is so? Maybe one of the things that we also have to discuss within Belgium and within our data, that you say, well, don't look at mortality or readmission as single indicators, but there is always a link. And maybe, like Bianca was saying, we are also looking at length of stay, to also try to combine the length of stay and the variation within the length of stay data also to include them in these analyses.
Yeah, you know, I don't know. I'm not the policy maker in the room. It seems to me intuitive that you would look at multiple things simultaneously. Like I said, you know, when I go and talk to my primary care physician, we talk about all of these things simultaneously in one conversation. Like, you know, but I think that at least from my perspective, most of the statistical methods that are out there pretend as if you're thinking about one thing and it's completely agnostic and to the other. It just doesn't seem. There's a misalignment there, and so yeah, I don't know. I'm not 100% sure what all of the sort of the actual complications are in going down that path, but it seems intuitive to me.
Okay, and I'm sure that Bianca will be in touch with you to have further statistical discussion about it. That would be really helpful for us. So thank you, Sébastien. Larry, some takeaway messages from you?
Yeah, a couple. One is I agree with the comment about length of stay. In the United States, the dominant financial factor remains length of stay, because we get paid for most of our 80% of our hospitalizations. We get a lump sum for the hospitalization. And so you get your money, and then your goal is to get people out as quickly as possible. And so even though we're talking about these metrics around readmission and mortality and publicly reporting them and even having penalties, length of stay is really still dominant. And so I think these are great discussions to figure out, well, how do we get these readmission and mortality metrics to be fair, so that we can place greater emphasis on them in terms of payment and other policy changes. So this is a great discussion. I think the second thing I'd say is, I think you nicely highlighted by putting this together that the solutions to this are multifactorial. And you also made the comment that 10 years in this realm goes by pretty quickly. And this is, it's a learning, process. And the goal is just to continue to get better and evolve. And clearly we're all doing that and learning from each other. And the last thing I would say is I feel like I've been on way too many US centric discussions. And I want to compliment you for reaching out and creating an international webinar today. It doesn't happen very often. And, kudos to you. Thank you for having me. I learned a lot.
Thank you, Larry. Thank you. Jauke, a final takeaway message for our delegates?
Yes, well, Chris, perhaps for the policymakers, it's important to realize that it's useful, but it's not the ultimate truth. So if you are going to use it, look for the stories behind the data and the ASMR and the SMRs. And perhaps for our colleagues in the hospitals, the board members and the doctors and our colleagues in the hospital, also see it as a possibility to talk about outcomes in your hospital. I found out that it was really a useful entry point for the discussion. So perhaps, Chris, that as a final take home.
Yeah. So I think it's important that, so as you say, that we have to take our time, but also what I will remember from your talk, how necessary it is to combine the know-how from the statisticians and the know-how from the clinicians, and to have these discussions. These are not always easy, but it's necessary to make these links. So thank you for that. That brings us to the end of the seminar, and I want to thank Larry and Sebastian and Jauke again for their presentation. I want to thank our colleagues from the federal government to give us the opportunity to provide and to organize these type of webinars within their patient safety work. And I see some of the colleagues are also with us online. So thank you very much for the ongoing support to the university so that we are able to organize these type of webinars on these important issues. I thank my colleague, Professor Dreder, who was also in charge of this evening, and Dr. Kugelbergs for organizing it, and to the two persons today here who did most of the work, back office in preparing this workshop, not only our lead statistician, Bianca Cox, but also Astrid van Wilder. Thank you, Astrid, for preparing everything in detail. As usual, as we are, well, we know from a pharmacist, it's behind the comma, and it's in detail prepared. So also today, also all the preparations with Larry and Sebastian and with Jauke, thank you for all your support and work. So we remember it's about trust, it's about respect for each other, and it's about a creative but also a positive mindset. It takes time, but one day we will be there. So thank you again, and see you at a next opportunity during one of our next webinars of Leuven University. Thank you and enjoy your evening.
Bye-bye.
Thank you.
Thank you all.